So I just hit record and now want to officially welcome everyone to this month's call of Open's Medicaid Adult Dental Benefit Learning Collaborative. Before we get started, I want to ask folks to please keep themselves on mute while they're not speaking. Feel free to use the chat to post questions, make comments, share resources, and also take yourself off of mute if you'd like to speak. You can do that by hovering your mouse over the microphone icon in the lower left-hand corner of your screen, or if you dialed in, you can do that by hitting *6. So with that said, I'm going to turn it over to Stacy Auger to lead us into today's discussion.
Thanks so much, Stacy. So great to see everyone, and I'm so thrilled to be with you. I've not been live on these calls for a couple months, so it's great to be with you in person, and appreciate you all so much for making the time today. We've got two big agenda items today, and the first is our regular standard round robin, where we hear from all of you about what's going on in your states and any new happenings. It's really an opportunity for you to share what's going on and also just lean in and ask for feedback and advice and guidance, and let us support you in that. Then we're going to use the second half of the meeting to talk about preparations that are happening at the federal and state level as we come to the end of the public health emergency. And we're going to talk about how states have been preparing or how they can prepare for this ending and really look to lessen the impacts of some redeterminations that are coming. So these meetings always go quick, so I'm going to dive right in and just open it up. It's been a great, I think, legislative session for many folks. We've had lots of great wins that we've been celebrating over the last couple of months, which is awesome. But there's still lots going on, lots to be done. And I just want to open it up and see if anyone would like to jump in with an update from their state on what's happening with their adult dental benefit program in their session, all those good things. So I'm going to go on mute and let someone jump in.
Stacey, is this a good time to ask my question?
Oh, it sure is, Ellen. Go for it.
In our state, the governor proposed in February as part of our executive budget to consolidate all the Medicaid dental programs into one. So we have a very successful kids program called Healthy Kids Dental. We have dental as part of the Healthy Michigan program, which is Medicaid expansion. And then we have this archaic fee-for-service dental program, which I say archaic because the rates haven't been raised since the 90s. And we had a virtual roundtable with the media on yesterday morning, and one of the reporters asked if any other state had done the same thing that governor proposed, which is consolidating all the Medicaid dental into one. I wasn't aware of any state that's done that. I asked Stacy, she wasn't aware, but I just thought as long as we had you all today here, we'd ask if anyone knew of any state that had done that.
We have not done it, Ellen, in Minnesota, and we have a lot of different game boards that everybody has to play on by age or program or all, which and managed care organization it is. But in 21, there was legislation passed for us to undertake a dental home demonstration project. And I think that could move us in that direction because it would, and part of the charge is to move towards value-based purchasing as well. So there could be some elements about that like, this is what you have to deliver and all of this variation that is supposed to improve access and make people happier and healthier, whatever, which over 20 years has not accomplished that it would be sort of a refocusing. So although we had a fizzle, this is my report from Minnesota, we had a fizzle fest legislative session due to people being more concerned about campaigning than finalizing bills because they didn't have to, it wasn't a budget year. So we didn't get the dental home demonstration projects are still in play, but we didn't get some additional legislation that would have mapped out dollar amounts and timelines and all that.
Thank you, that's interesting, helpful.
Hi, this is Sam from Rhode Island. We kind of like Minnesota, that we have a bunch of different programs. Our children's program is in managed care and our adult program is in fee-for-service. In discussions with our new Medicaid director, I think a long-term goal would be to have everything in managed care because if we want to take advantage of the new accountable entities structure, that's what we call it in Rhode Island, accountable care organizations, different things here, we call it accountable entities, that if we want to take advantage of that, if we want to take advantage of like the total cost of care concept, we'd have to have it all in managed care. So, and she wants to do that in the future. The good news in Rhode Island is we did get a rate increase for the adult program. Again, like many of you, hasn't been changed since the 90s. So that's really positive. We had proposed all of these different budget items. The governor didn't initially push any of them through. Then he reached back just for one, and that was the one that went forward, was the rate increase. So some of the things that we wanted, like silver diamine fluoride for adults and a bunch of items, unfortunately didn't make it. But this is a win. And again, good to be here because I want to hear about some provider engagement strategies and some consumer engagement strategies, because hopefully, so anyway, so that's the update from Rhode Island.
In California, all of the Medi-Cal dental is in the same delivery system for all populations. So it's either fee for service, or in 2 counties, you can go into a separate managed care plan just for your dental benefits. And it's optional in LA County, and it's mandatory in Sacramento County. And there's been efforts to stop doing that because it doesn't seem that the dental managed care plans are doing all that much better than fee for service. Although for advocates, it gives a different route it gives a separate appeal route to try to get enforcement. So in that sense, there can be additional enforcement mechanisms. There are other initiatives like dental health homes and other initiatives that help increase provider rates or expand services for certain populations, but the delivery systems are the same. And then there's one county right now, San Mateo County, which is a small county that has taken, as Sam was talking about, taken dental into the managed care, the Medi-Cal managed care plan. So that's responsible for all medical benefits. And they're piloting that to see how that works. But I think, as like Sam, you were saying, I think the idea is that that would integrate it, and then you can better assess the value-based aspect of it because it's all in one delivery, like one full delivery system instead of dental being kind of carved out from everything. So I guess, Ellen, to your point, like California has always been the same. So, and then when adult dental was taken away, it was taken out of that delivery system and the benefits were just eliminated. But then when the benefits came back, it was through the same delivery system mechanism.
That's
And
helpful. Thank you.
this is Pat Finnerty from Virginia. We have all of our program in one administrative structure that is administered by a dental benefits administrator outside of managed care. We built the program incrementally. You know, originally it was for children, and we had some very limited services for adults. Then we added pregnant women last July. We added a comprehensive benefit for adults, but it's all under the same administrative structure. It's carved out of managed care. We operate that through a separate dental benefits administrator. DentaQuest is the current administrator. And while I'm taking up your valuable time, I'll just mention our legislative win is we did get a 30% increase in rates. It's not going to be official until Friday. We went into overtime with our session, but we're fully expected he's going to sign it, and that'll be our first increase in 17 years.
Well, I'll just jump in there on the back end of that, Pat. That's great news. Missouri's in a similar situation. We're going to jump about double, actually, for the dental rates in Medicaid, provided that the governor will sign the budget. We expect him to. It's not uncommon for Missouri governors to wait right till the end of June to sign the budget, though, with it, it going into effect July 1st. So there'll be a little, staticky kerfuffle with that for mostly providers. But anyway, that is going to happen. And a little bit, yeah, and it is great news. I mean, we're delighted. There's some problems with it, but we're delighted to have those problems. And this is a little bit of a tangent. There were some comments about wanting to have all of Medicaid in a managed care plan. Do people not run into the advocacy community for people with intellectual and developmental disabilities just like having a fit about that? I mean, just throwing up roadblocks right and left. I mean, the phrase I've heard many times, including from a board member, is managed care is bad for people with disabilities. Are other people not experiencing this? I'm just curious.
We haven't experienced that in New Jersey because those are the populations that have care managers. So they have that extra person to help them navigate the program, the benefits, access to transportation, other social service needs that they may have. So we haven't had that pushback. But additionally, we just finished a project where we have improved our directory of dentists that are treating individuals with IDD, and we are now moving it into a provider search platform because the directory is, it's just an archaic way to list providers. It changes by the time you print it. But that's what the advocates asked for. So when you wanted to give them a search, no, they wanted a directory. So they have the directory. I think now they're understanding the limitations of that. Additionally, we tried to add additional information to that directory to just advise them that they should use the care managers, that's why they have them, to assist them in identifying a dentist. And we also developed a little fact sheet to assist them in interviewing a practice when they call, because there's just logistically no way to put down what types of patients a practice is comfortable in rendering services to. While it was easy enough to indicate if they have hospital privileges, that's still challenging because, 3 hours for a dental case when you could see 4, whatever procedures done in that time. It's just difficult to push the needle on that access point. But I have not heard that as a complaint from our IDD members, as well as our MLTSS members also have care managers to assist them with access to care.
This is Deb, and I just wanted to say, similar to what Bonnie was just saying, I feel like the IDD community, it depends on which of the managed care organizations, because we have multiples. And then that goes back to what's already been said about where's the transparency and accountability about how much is really going to care and all that kind of thing. So as we've gone back and forth and big factions within the legislature on who was supporting the health plans and who wanted dental carved out. I mean, seriously powerful legislators from different parties battling on that. Kind of the thing is, you could have managed care and have a bad situation, or you could have fee for service and have a bad situation. It's somehow having a process, but through which people are evaluating and looking at who's getting in, who's not getting in, what is the supply of OR time for dental and all that kind of thing.
That's very helpful, and I think what you're saying is reasonable. I would say, going back to when they established Medicaid managed care in the state, there was a process established where you could opt out and stay in fee for service. And to my knowledge, the majority of the population of people with intellectual and developmental disabilities to this day opt out and do not play in managed care very much. So it's all fee for service. The case manager kind of thing that you brought up, Bonnie, that's interesting because I think there's a lot of room where there could be much greater emphasis on oral health needs among those case managers. Right now, I think they're probably not too good at that. I think that's probably an afterthought, like it is for so many people. Other than that, I just want to say, Amber, are you actually going to drive all the way from California to Missouri?
I live in Missouri now, Gary. I'm in Kansas City.
Oh, okay. Well, that's easy then.
4 hour. I mean, I still just feel like I'm in California because I talk about it all the time, but
Yeah. And then you walk outside, the humidity hits you. and
Yes.
I'm not in
It's
California.
oppressive.
Yes.
I did want to say on the IDD populations, that's fairly common across like that opposition to managed care. And there are a lot of reasons for that. A lot is around the fact that you want to have autonomy and person-driven services and supports. And when you bring managed care into the mix, you have a lot of utilization controls. So for example, in California, the biggest long-term services and supports benefit, the personal care program, which there are about 600,000 people enrolled, it's carved out of managed care because there was such deep opposition from the disability community, all people with disabilities, that bringing that into managed care would erode that sort of person-driven, consumer-directed model. And I think in managed care, some like Bonnie, what you were saying, I think there's been such a, like some of it is just like a steamroller. So you're like how fast the states can do it and how much. But in New Jersey, the only thing I've ever heard there is that there is some discussion around conflict-free case management. So having the same entity that is assessing you for hours, also fiscally incentivized not to give you hours, is pretty, you know, there's a terrible financial incentive there. And so the idea of creating some sort of intermediary, and so there are some state examples like that, but generally I think, Gary, what you're seeing in Missouri is fairly common. It's just how much the state wants to pursue it for the population. Yeah, and sometimes that the population gets carved out, which can be both beneficial or not, depending on what's happening in the managed care plans.
And I would say another thing that we have started doing finally is looking at the metrics. So we pull the IDD population out when we're looking at children's services. I'm trying to get to move into adult services, but for children, we're pulling out that IDD population to really look at their utilization of dental services. And we did have a conversation with the care managers, supervisors for our 5 MCOs to tell them that we will also be looking at the plan of care to ensure it includes dental. Because you're right, it doesn't hit the board at all in some cases. And when we're looking at utilization, it's just hard to know when you're looking at utilization until you drill down to find out, is it because there were, extenuating circumstances, medical concerns that superseded the dental, the parent didn't understand they had dental, they got one appointment that was canceled, or they broke the appointment, they never made the time to go back and make the appointment. There's just so many other nuances, but until you start looking at the metrics to just see who's seeing a dentist and getting services, it's hard to just put it in a contract and think it's going to happen.
Thanks, everyone. Mary, I noticed you've been shaking your head. I want to know if you want to jump in on any of these pieces. I don't mean to call you out. There's a couple of faces I can see.
Wow, remind me to keep my head still. No, I'm only kidding. I'm only kidding. Actually, I'm really happy to report that Maryland's keeping with the trend of all the good news with other states on rate increases. Along with the adult dental in the budget, there was also an additional $20 million put in the state budget for increase in Medicaid dental reimbursement rates. And Medicaid reached out to MDAC, similar to what they did with the pilot program, and asked us to pull together a stakeholder advisory group that they can talk to in terms of how to spread the $20 million out. So I went to our network and I really pulled together a diverse representation of Medicaid providers in terms of geographic. I had urban, rural, suburban, as well as provider type. I had private, local health department, FQHC representatives, and we met 3 times, and it was really an incredibly robust, that's what they say, robust, when everybody agrees in a very polite or disagrees in a very polite way, a very informative, robust conversation. But in the end, it was really nice to see these providers, different types, really come together in agreement, in general consensus, that rather than go across the board where it would only be a 4 or 5%, 4% increase spreading the 20 million out, that they were going to focus on the codes most utilized in the Maryland Healthy Smiles programs for children and eventually adults. So they identified 32 CDT codes, which is translating into now a 10% increase in Medicaid rates for those codes. And they believe that this will provide incentive for Medicaid providers to stay in the program, as well as recruitment of additional providers to join Medicaid in anticipation of adult dental in January 1. So it was a very interesting, good process. So I'm glad we were a part of that.
That's great. Mary, thank you and congratulations. That's wonderful. And I am sorry to have called you out. I hate doing that to people. I just
Call me anytime, Stacy. It's okay.
Thank you. Any other updates or questions you want to pose to the group before I'm watching the clock, change gears?
I had a question for Ellen. When she says that the legislature is pulling all their dental programs together, what does that mean?
So the governor is actually what proposed it. So we've had a managed care program that's like carved out from the health plan. So it's gone to dental health plans, specifically Delta Dental and Blue Cross, that just deals with kids. And then we've had the adult fee for service. So she said instead of having like different contracts for different things and it managed in different ways, that all people who are on Medicaid who have a dental benefit would be in one consolidated managed care program that would be carved out from healthcare.
Okay. But I didn't understand. Are they all going into managed care? And
they're all going to go into managed care. Yeah, so that was what the governor proposed. The House and Senate both proposed to keep the current structure and just increase the rates in the fee-for-service program. And the dollar amounts were drastically different. It's right now, it's at conference committee. So the House and the Senate and the state budget office are all negotiating. And so we don't know what the final product will look like quite yet.
That sounds treacherous, Ellen.
It's like, it feels like hurry up and wait. Like things are like, you've got to do this, send out this email immediately. And then you just sit and wait by your phone, hoping it'll ring. And then like last Friday was the last day of school. So in the afternoon, I was running my daughter all the places. And then I get an email through our website contact from somebody I had never heard of at the state budget office, where we've met with the state budget office like 3 or 4 times, asking what utilization was in commercial. So, I'm like trying to answer these as I'm taking my daughter to a haircut and to trade in her trombone for a French horn. So I'll be excited when it's done. I'll be able to breathe again. And as soon as we get something, we'll let you all know.
Exactly what I was going to say. Thank you, Ellen. Keep us posted. Please do lean on everyone, and know we're sending good wishes for you to catch your breath very soon. I know lots of folks can relate to that. So I'm going to, sorry, did I cut someone off? I'm going to switch gears, just keeping track of our time, which is not always my strong suit, so working on that today. I'm going to turn things over to Melissa Burrows with Families USA. We've been talking on this call in the past a little bit about public health emergency coming to an end, and when that happens, Medicaid starting up the process of redeterminations again, and what that might mean for lots of folks across the country. So Melissa's going to talk us through kind of what this all means, where we are now, and help us think through what we can be doing. Melissa.
Thank you, Stacy. And I'm going to give just a brief amount of background. So if folks have questions or want more details, just let me know. I can talk about it at a slightly more detailed level. But as a reminder, the Families First Coronavirus Response Act, which Congress passed relatively early in the pandemic, meant that states are getting extra federal funding for their Medicaid programs as long as they meet certain provisions. And one of the things, and that would continue through the end of the federal public health emergency related to the COVID pandemic. And one of the provisions of being able to receive that funding is that states could not terminate Medicaid coverage for folks that were relying on the program during the pandemic, and that included, through the process of redetermining their eligibility. So states, in some cases, have been attempting to keep their data up to date, but many have not. And throughout this, now several year period, people that are relying on Medicaid for their health insurance have not had their eligibility checked, and then they have not lost coverage because the state has determined for any reason they're ineligible. So when the public health emergency ends, there is a significant looming crisis when every state resumes this process where they will check people's eligibility for the Medicaid program, and that will be allowed to terminate coverage for people they deem ineligible. However, the process isn't that smooth. If states were really truly determining people's eligibility, that would be one thing. But what this process usually looks like is relying a lot on direct mail, relying a lot on outdated information and data, relying on materials written in languages that you may not speak or that are at reading levels you may not understand. They may require technology that you don't have or are not able to use in order to update your information. So this is a big issue because it's a huge undertaking for every state, and it's not likely to go very smoothly, and it could result in a lot of people losing coverage who are eligible for Medicaid coverage, and a lot of people who rely on Medicaid coverage for both their medical and dental coverage losing that. And this is true for children, adults, older adults, people with disabilities that are relying on Medicaid, anyone who's relying on Medicaid. So this is coming. The good news is that the federal public health emergency will not end until at least October. This is new information. The public health emergency was slated to end in July, which is why we specifically made sure to talk about this issue on this call. But they said that the federal government said they would give 60 days notice before ending the public health emergency. So we're past that. We know they won't end it in July, and they will extend it. Which means we're looking at least October. There's talk that it could get extended again into next year, or really to the end of the year, since October is running up against election season. But regardless of that, states are making plans to how they're going to address this problem now, and some states are starting to do parts of the process that they can do without necessarily going so far as to reassess eligibility. So this is a big issue. It's something that Families USA has been thinking about a lot in terms of how can you work with the federal government to make sure that they're supporting and overseeing states' activities in ways that make sure that the most people who should be in Medicaid coverage retain their coverage. It's about working with states to make sure they're doing the same. A lot of what we're interested in and what's written about in this brief that was just shared in the chat is maximizing certain types of renewal processes that leverage data rather than leveraging mail to make sure that someone is, to double check the information about a person. If they're relying on other programs where their information is up to date, then you should use that information rather than, mailing them at an address where they may not live anymore. So that's kind of the scope of the problem. Part of the initial discussion of solutions, but a lot of what this is going to come down to is community engagement and providers working with patients and making sure they understand the problem and what's likely to happen. And everybody working together. So that's sort of where we are. And I'd love to have a conversation about what you all are thinking about, what you're worried about, what you're hearing from your state. because this does impact the very people we've been working so hard to get dental coverage for.
So thanks for the update. That's interesting and very concerning. It has been talked that this issue has been talked about to some degree by the health advocacy community in Missouri. And we are a little bit more focused on Medicaid expansion and the enrollment of the expanded population. I think regulation requires enrollment within or at least review within 45 days after an application. We're now, for the expanded population, setting on over 100 days. There's 70,000 people in the backlog, and the agency is remarkably understaffed. There's been a lot of exploring with the feds, you know, with some people having the idea, well, they've got the purse strings, maybe they'll go beat them up. And of course, they're not going to do that for a lot of reasons. And, you know, we are kind of trying to figure out how to light a fire. And of course, with that looming, I mean, that's just going to compound things. I will say, I don't think it's the state Medicaid agency's fault that they're dramatically understaffed. They've been hit up with the employee loss, and they are trying to do a lot to hire new employees. These are not considered great jobs, but they're out there trying to push it. So there's a lot of pretty difficult issues. I know there has been some explicit discussion that I apologize, I'm not an expert on, about, you know, the ending of the public health emergency and people going off of Medicaid, and how big is that population and what can we do to help. There's been discussion about using the federal enrollment system to help with this. I think our Missouri IT systems are antiquated, and there seems to never be enough resources to update them appropriately. So it's a very complex, challenging issue.
Well, this is Pat. Just a quick update from Virginia. The Medicaid agency here has actually been doing a lot of work on this. In fact, I was at a board meeting yesterday, and they made a presentation about their efforts. And I know one of the things that they're doing is they're implementing some systems, some computerized systems to increase automation, kind of no-touch processing, to make sure all of that goes as smoothly as possible. And they're kind of in the middle of all of that. They have a really nice set of maybe 7 or 8 slides that give a pretty good view of what they're doing here. And I'm happy to get those to maybe Stacy and Stacy, and let them send it out to the folks if it's helpful. They're expecting, I think the range they said yesterday was, the expectation was between 14 and 20% of folks could you know, be determined to no longer be eligible. So it clearly is a big deal, but I haven't been following it really closely, but I just saw this yesterday, and I think it might be helpful to folks, so I'll send it along.
Thank you, Pat.
I can talk about California a little bit. They've also been doing a ton, and I'm actually going to put their plan in the chat. They sent out a mailer in December of 2021 to sort of get a sense of how many people they don't have accurate information for, contact information for. And they got a 12% return rate, which in California means almost 2 million people that they would just lose eligibility based on not being able to get in contact with them. So the state's doing quite a bit. And I think it's important to think about it in 2 buckets. They're doing a bunch of work on thinking about what programmatic flexibilities will end. So under the public health emergency, for example, dental providers are getting streamlined applications to become providers in the program. That flexibility, when the public health emergency, that authority to do that will end. So they're assessing whether some of these flexibilities they'll keep in place. So things around provider enrollment or assessments being done in person or virtually, telehealth, which obviously there's been enormous expansions in teledentistry. And that's been in part possible because of the public health emergency waiver flexibilities. So are we going to keep those in place? So I think that those are areas for us all to be considering in the oral health space, is sort of these programmatic flexibilities under the PHE. And then of course, as Melissa noted, there's the eligibility loss. And there are a lot of different things states can be doing to maintain eligibility or mitigate loss. And that could be, in California, they're not prioritizing populations for redeterminations. It's based on the renewal month. We were kind of pushing for certain populations to be deprioritized in the renewals because they were least likely to lose coverage. But they decided that simplicity was a principle for their PHE unwinding, and that prioritizing populations got too complicated for that. But their plan kind of spells out how they're going to go about those renewals, and then taking up a lot of the federal flexibilities to mitigate disenrollment. So things like ex parte review, expanding that to all populations and not just children, to presumptive hospital eligibility. So sometimes that's not available to all populations, and under the PHE, they've expanded it. They are thinking about in the ex parte reviews, like if income had been, they would reassess if there was a difference between what was like reported through the ex parte review versus what they a person reported on their application. They're expanding the percentage that difference can be to give people more benefit of doubt. They've implemented a policy for self-attestation when there are discrepancies to mitigate the barrier that presents when people have to prove their assets. Of course, you could always eliminate your asset limits for populations, but I don't think that goes over well in states. But it has happened. California just did it, and other states have really significantly increased them. But aside from that, there are just some other flexibilities that states can be taken. I think the other big piece that California has undertaken is outreach and education. So they've created an ambassador program where anybody can sign up to become an ambassador and hear all of the information that they're getting about the PHE, from like how notices that they can send to people. The big phase right now is just getting people to update their contact information. They also are they've discussed how they're going to include managed care plans in this effort. And I think the only area where I think the state could really step up in its outreach is thinking about oral health providers and other types of providers and what role they can be doing in the outreach and education. So that's an area that we're uplifting among some other policies. But I think like a state like California is doing a ton. But Gary, in Missouri, I tried to look up if there's a plan available, and I couldn't find anything. And like you said, it's being compounded by the fact that there's already a backlog of people that they haven't even assessed for eligibility for expansion. And then how many of those people they've assessed will suddenly like lose it once this happens. And so I worry where there are states that things aren't as transparent and there doesn't seem to be as much resources dedicated. And then of course there are states that have affirmatively said that they are going to try to get people off their rolls, that they aren't going to try to maintain coverage. And so those states obviously are very problematic. And I'll just say like Florida and Ohio seem to be two of the problem states there.
Thanks, Amber. So along those lines, I actually want to hear from others and what concerns are you hearing or seeing? To Amber's point, are you in one of those states that is actively looking to disenroll folks? We'd really like to open it up and just hear from everyone. I will also say I'm interested to hear if anyone has, Amber shared about the ambassadors program, if there's any really interesting or unique, something that's able to be replicated in their states around outreach. I would love to hear about that as well.
One thing that is not an update, but that I should just clarify, is what ex parte renewals are, which essentially, and I know I was throwing around this word and several of us were throwing around this word or this term, and it basically just means automatic renewals based on data, where you don't have to have an individual attest to or indicate that their information is the same or has changed, but it actually can check that and automatically renew them without going through that process of outreach. So sorry for being wonky at you.
I love the wonkiness, Melissa. Thank
I
you.
personally appreciate that clarification. Thank you.
I'll just note too on the ex parte reviews, like some states have been using those systems to disenroll people and relying on inaccurate data, which happened in Missouri. Just a red flag all around, where they're relying on data like from a LexisNexis database that's outdated or it's not the person at all. So we have to be careful on that part, but to the extent that it can expedite enrollment or approve enrollment or automatically renew enrollment, it's very beneficial.
Yeah, Missouri is not going to be real clean about any of this stuff. And speaking of bad data, I mean, I personally have heard multiple stories about people being mislabeled as actually living in another state, and then like getting in there and worming around in that system and trying to figure it out. It's just like hitting your head on a brick wall. It's very, very difficult. So I hate to be cynical about it, but I'm certainly not optimistic.
I'm gonna do something again that I hate doing, but Laura, I'm actually looking at a post that a comment you made in the chat that I wanted to come back to, if you don't mind, talking about the bridge task force. I wanted to see if you would talk a little bit about that. I also wondered if, and I'm not sure if you knew about this, I saw a notice in the last month or so about a group coming together in Oregon looking at ways to engage consumers around redeterminations. I'm going to try to pull it up while you're talking about this, but if you have any information on that piece, I'd love to hear about that. And I'm sorry to put you on the spot. I appreciate you hearing me.
I'm wondering if that's tied to the Bridge Task Force, Stacy. I'm not sure. So I put the link to the bill in the chat, but obviously we're going to have a lot of people coming off plan. And so they passed the bill to create this task force. It's like they want to do a bridge program that will let people have affordable care and keep the continuity of care going for people that are going to come off plan. And so basically this task force is charged with figuring out how to do this. They met yesterday. They have pretty good representation. They want to make sure that oral health they have an oral health representative on the task force, which was great. But they want to, I think the discussion was for the benefit for oral health was just basic, what we used to call standard, emergency exam, x-ray, and extraction. And we've all said that that's not good enough, that we need the same benefit as what our Medicaid members have now. And so I think what they're proposing is a potential like small premium for these folks, something that they can afford. I think it's going to be people that are 200% below the federal poverty level. But basically, they want to make sure that these people that are going to come off plan have a way to potentially keep some sort of benefit with a small premium. And so you can read the bill in there. Like I said, I put the link in there. I hope that makes sense. It's a little, and Christian, you can help me if I'm got this wrong, but and also I I stuck in there that we just lost our state dental director. He just gave notice and Friday's his last day. And I'm just like, it took almost a year to get Dr. Raffia, and now he's leaving. And I'm not sure why we seem to have such difficulty with that, but now we're going to be without a state dental director, which is, I mean, I think there's enough people in Oregon that are really good champions for oral health that we can keep the work going, but not having a designated state dental director, I think is going to be tough for us. But it's not going to affect this bridge task force work. Did I miss anything, Christian? Okay.
Thanks, Laura.
I will just jump in related to that. It's been interesting. Oregon has this task force and they're figuring out this set of solutions. Kentucky is implementing a basic health plan, which is kind of a similar concept. West Virginia is considering some things like this. So there's definitely some questions as to what that would mean specifically for dental coverage in any of these states. But it's not, this is something that's popping up a lot of different places, some of which is, directly in response to this crisis around redeterminations and the need for more continuous coverage. But, in places like Kentucky and West Virginia, the conversation is a little bit different. But it is an opportunity in those states to, build a Kentucky solution or a West Virginia solution that's different than Obamacare to solve these problems. And I do think that's something to keep watching, because there really is a lot of opportunity both to address this problem and to make coverage more continuous for people whose incomes fluctuate.
So while I'm in the meetings, it's really not something that we're doing, but I do know that many of the things that I've heard are occurring. I know that redeterminations went out even during the public health emergency so that we would have an idea of where our members are in terms of maintaining eligibility or not, even though that will go out again. We're working with the managed care plans to assist us in getting a list of those who received a redetermination packet and did not return it. And then they're identifying if it was a bad address or if it was a good address, but they just never responded. I know that they also have letters and a toolkit that are in the works that will be shared with our partners, including like WIC and Head Start programs was mentioned. And that they're working with the county welfare offices because that's who will be doing some of the redeterminations to ensure that it occurs in a timely manner. And they're also rolling out the information to members or to the MCOs. I'm not sure which one, but I know it's a rollout so that they can control the amount of redeterminations that are coming in at any one time. And I think that's all, at least that's all that I wrote down in my little notes that I can sort of decipher.
Thanks, Bonnie. Other folks want to jump in? Things they're doing or seeing or hearing on this issue? Okay. Well, this will be an item, among other things, that we'll be watching and talking more about it as things develop. I appreciate you all for sharing today. We do have a few minutes left, and I wanted to just, Stacey, I know you made a plug at the beginning to remind folks to register if they hadn't already for open, but I didn't for the open meeting this summer. I don't know if you had any additional information you wanted to share or updates generally that we want to close with.
That's our big update. So again, if you haven't registered, please go ahead and do. And we have some additional scholarships available for partners of yours who you may want to get involved in the network and join us at the convening. So please share the link with them as well. Reach out to me or to Bianca Rogers with any questions about that. And it's going to be an awesome conference. We have some great keynote speakers lined up, some great workshops, featuring our incredible network members. So we hope to see you all there.
Thanks, Stacy. So just before I let everyone hop off the call, I just want to flag it. The chat has been going like bananas today, which I love seeing. There's been lots of great resources put in there. I know a couple other folks have sent me some things offline that I will compile and share with Stacy Chazen. So we will get those around after the meeting and in the coming days. And of course, in between, you know, between now and our next time together, please be in touch with us, with each other, share resources, share ideas, share all the things. And with that, I will let us hop off a few minutes early. But again, I just want to thank you all so very much for joining us today. I hope that you're well. For those traveling, travel safely, and we'll see you all soon.